textbook chapters on topics of enteral, parenteral, and ICU nutrition, and has several peer-reviewed publications. She currently serves as a faculty member for the ACGME ACCM Fellowship Program at Washington University School of Medicine and the ANP program at Barnes-Jewish Goldfarb School of Nursing. She's won numerous awards, including from last year the Medal of Excellence as a postdoctorate student from Rutgers University and the Advanced Clinical Practice Awards from the American Society of Parenteral Nutrition and the Academy of Nutrition and Dietetics. Dr. Taylor states that she most enjoys caring for critically ill patients and clinical bedside research. She currently is working with a multidisciplinary group to study the effect of a mobility program and optimal nutrition provision on the rate of muscle loss in the ICU. Today, we're honored to host Dr. Beth Taylor for her presentation on nutrition in the ICU. Please join me in welcoming Dr. Taylor. Party so we can get the slides up. Give us just a second.
Oh, you all teed up too.
We had it. Maybe go back to kiosk. Is it showing preventive use or something?
Good.
Yeah. All right.
All right, I just want to thank everyone for their patience. This is Dr. Beth Taylor.
Am I supposed to hold this little thing?
You can clip it on.
Ah, okay. Well, thanks everybody for coming and for the invitation. I'm really happy to be here. And also for the remote sites. That's pretty incredible. Technology's come a long way. So hi out there on the remote sites. Oh, I didn't touch it, I swear, but this little thing is coming up. So what I'm going to talk tonight is this talk, I kind of have it divided into 3 sections, and my hope is you'll be able to have all these slides, but I won't get to the last section because I really want us to have some interaction and discussion about things as we go through, and I'll pose some questions to the audience, and I'll start at the back and make people answer, see if those people are scared that sit in the back. So we'll see what we can find out, because like anything in medicine, it's the practice of medicine, right? So we're learning as we go along. Now let's see if it can advance. Okay. It's up there, but it doesn't want to advance, guys. Hello. Help. It won't advance. I'm. But isn't this a great first slide? I mean, come on. I'm. Play from current slide, maybe. Does it still show up okay there? Well, now that is just not good. I guess we have to do it. We should try. There we go. Does that still work okay on yours?
I'll double check.
Okay.
I think if you're okay for that.
Oh, yeah. So I don't have any disclosures. And I put this pictures up. Does this look familiar? Doesn't that look like the bedside of a lot of our ICU patients? Like there's a million things hanging. So we have a lot to keep our eye on. My objectives today are just to talk about some of the new data that's out there regarding feeding ICU patients. And then I was asked to focus a little bit on the obese ICU patient and the use of Immuno Nutrition. And then lastly, barriers to feeding in the ICU, which we may or may not get to tonight, but that's fine. First of all, I think we all agree it takes a team approach. So the care of the ICU patient, I don't know if anyone went to the SCCM plenary talk last year by Vignay, but he did a great job of pointing out that we don't want individual champions. We want a championship team. So not a team of champions, but a championship team. And we're all members of that team, equal members working together to give the best care for our patients. And it takes so many of us because there's so much going on at one time. It's not like this pretty empty room, and your pretty empty rooms look like our pretty empty rooms, but it's all these things going on. So if we just say it's just your responsibility to watch this and that, it doesn't work. You all have to be each other's safety net. So if you think about when I'm rounding in the unit, I'm the safety net for electrolyte repletion, fluids, glycemic control. That doesn't mean I'm always that person responsible, but I'm making sure that that gets addressed on all those patients because my physicians are working on other things at the same time. And we use things like guidelines a lot, right, because we want to do evidence-based practice, and this is a means of improving the process of care. But guidelines are great, but we have to figure out how to implement them. And the new guidelines are coming out for sure in January. They're going to be released at Clinical Nutrition Week, and at the moment they're being released there, they're being released online through SCCM and JPIN at the same time. And how many of you guys use a protocol, a checklist in your unit? Does anybody use a checklist, rounding, check off, like make sure you've covered everything in your unit? So that's something we instituted, and that actually helped us catch a lot of errors. So you can't see it, what we call the CHUG. It's our daily checklist of unit guidelines. And basically what we're doing is to make sure we've addressed everything. So we round on a patient, and then we do the CHUG, which means we say restraints covered, sedation covered, telemetry covered, nutrition covered, and then we'll know if we didn't talk about something. And then we do an order readback between the nurse and usually the fellow. Especially in teaching hospitals, when you have young interns, July can be scary sometimes, right? Making sure all the orders are in there right. The other thing we have is we do use a lot of protocols. We have a lot of nurse-driven protocols. We ask a lot of our nurses at bedside to get care done as it happens real time. So in other words, you don't always have to, I don't know why this keeps popping up, you don't always have to call the physician for every order. But there's some pros and cons about protocols. Does anybody have any thoughts about protocols? How many of you have an electrolyte repletion protocol where you work in your ICU? Okay. And is it nurse-driven? And so if you went to one of your residents, would they know how to do electrolyte repletion? So I think that's the challenge. We had this thing is I know many moons ago when you're old, never remember. My residents would order 48K and no matter what those levels were, right? That mag was 1.2, they got 2, and that's what they were used to writing. So we came up with a nurse protocol based on renal function, et cetera. But I know there's good and bad protocols help standardize care, so we give the same care to all our patients, and nursing protocols, sedation protocols. But you have to know the why behind the protocol. So I think in teaching hospitals, we often remember that we teach the why behind our protocols. So let's look at some of the new discoveries in ICU nutrition. And I'm sorry about that. I have no idea why this is coming out. There's a new way of thinking out there. Is that guess what? All our ICU patients are the same. There's a novel idea, right? So perhaps those patients that are really well nourished and are going to be those 2-3 day turnaround ICU patients, it may not make a whole lot of difference. Don't shoot me, but what we do for those patients nutritionally. Those patients that are already somewhat malnourished and are going to be with us for that week to 2 weeks, it will probably make more difference for those patients how we act in those first few days. The problem is we don't always have that crystal ball to tell us who is going to be that long-termer or who's going to be that short-termer. But don't you guys have a gestalt? You know some of those patients that they're post-Whipple, they're doing fine, they're going out the next day. That's not the one I'm going to come in and pound my fist about, let's feed them in 24 hours or something like that. Big trauma, going to be there for a while. That would be the person I'm going to say, let's start feeding early. So a lot of what we do is probably based on are thought about the risk that patient has. So nutrition risk is similar to any kind of risk when we're trying to think of the risk of our ICU patients. So the higher the risk, probably the more benefit they're going to get from nutrition. And this becomes important as we look at those new studies that are out. How many of course, they always hit JAMA or New England, the one that shows underfeeding versus full feeding made no difference, the tight calorie control study. One, you look at that, and it was kind of, they were underfeeding both groups. But the thought is that there was no stratification for risk. And I'll show you a few studies where they did stratify for nutrition risk, and it seemed to make a difference in how you interpret the data. So this concept of nutritional risk is not new. It's been out a while. I'm not allowed to talk about the guidelines, but these next few slides may show up, okay? That we're going to suggest that with the wave of Aspen's push and looking at malnutrition and risk kind of go hand in hand. But the concept of nutritional risk does not look solely at nutritional status. It also takes into account their injury, their functional status, that type of thing. So there's two ways to determine risk. There's the NRS 2002, which you get scores for, the things that we're used to seeing, weight loss, what their BMI is or food intake. But then also you get scores for what they're there for, a major surgery or a head injury, that type of thing. And then there's the Nutrix score. And this is also taking into account disease severity. So I think as the nutritionist in the ICU, we need to broaden our scope. As I'm teaching my critical care fellows, I'm like, even nutrition, I have to know everything about those patients, right? I have to know their renal function. I have to know, their cardiac function for fluid, electrolytes. It all goes together, whether they're diabetic and they have stress hyperglycemia on top of that. So you need to know your comorbidities and their injuries and Apache score. So this is something I see in the future, that we set up our nice little app for that and we start to calculate those kind of things. And just to look at a few of those studies in this paradigm shift as we start to look at risk, and I know there's always some that are hard to see, but this one study down here looked at the top one, G, looked at using NRS 2002, and they looked at two groups, at high risk and low risk, and then they looked at meeting needs and not meeting needs sufficient nutrition. And you can see when they were high risk, nutrition made a big deal, made a difference in outcome. But if it was a low risk patient, it didn't really matter whether we fed them or we didn't feed them. So I think it'll be a new way to prioritize our day, kind of when we look at our patients, to kind of determine what the risk may be. And then this was by Dr. Hyland, a large observational study where he looked at the Nutrix score, and he did this one with no IL-6, interleukin-6, because I was like, nobody gets an IL-6, right? So he realized that, went back and validated, and basically showed the same thing. This is a 28-day mortality, which you can't really see. The big thing is those at high risk, though, decreased their mortality as their adequate nutrition went up, whereas low risk is pretty much a straight line. A few more studies, randomized controlled trials. So we're just now starting to get more trials, a little smaller, kind of showing the same thing, that again, if you're higher your risk, the more benefit that you're going to get from the nutrition intervention in all areas of length of stay, complication. And we compare that with, right now, with Aspen's definition of malnutrition, because they do kind of go hand in hand. Mostly we talk about an acute malnutrition in our patients, but don't a lot of our patients have an acute on chronic? And I think that's one thing to keep in mind when you're, as a dietitian, making a nutrition diagnosis of chronic or acute malnutrition, and then asking the physician to agree with you and make the medical diagnosis. You may have some of both. And I think that everyone needs to remember this is a very important comorbidity, just like high blood pressure is a comorbidity. If they have come in, especially to, like, they've been a cancer patient that maybe underwent an operation, their nutritional status will be poor at the onset. And because how we react, that actually makes them a higher risk patient, means we need to react sooner and get their nutritional care started. And it can make a difference. So we know what our characteristics of our malnutrition when we're making our diagnosis. Any two will be enough to identify. A lot of it, I mean, weight loss and intake are more objective measurements, but we have a lot of subjective about this when we're making the diagnosis. But also dietitians should be using their physical exam to help strengthen this diagnosis and convince the physician if you think someone's severely malnourished, you need to talk to the physician to get it on the diagnostic list. And we know that as we lose muscle mass, and what we see in our ICU patients as they become more acutely malnourished. So they may come in and not necessarily be malnourished, but by their second month, things can change. So don't ever think that you can't have a new diagnosis. Remember, think about that diagnosis list. Things get added, right? All of a sudden, now they have pneumonia. So they can develop an acute onset malnutrition. And as they have this loss of protein stores is when you see more complications. So we haven't quite cracked the nut on how to keep some of that from happening. They are going to have an obligatory loss, but we're hoping that the exogenous protein we give them will help slow that down and won't turn it off, though. So are you guys, tell me right now, who is doing malnutrition screening? How are you guys determining who's severely malnourished? Anybody? Dietitians, what are you doing? Okay. And so you're using intake and weight loss probably from that mostly, right? Okay. Okay. And is some of that automatic, or do you have to do it yourself when you go up to assess? So she's saying that she uses SGA. So we have, when our patients come in, our nurses do a patient profile. And some of the questions they ask are weight loss, intake recently. We use unintentional weight loss. But those responses get sent. We can pull that form out for the dietitian. So I could already see they've met 2 criteria if they ping on those 2. If they ping on one of them, then that would be somebody I know I need to go look at for the physical assessment. And I'm not saying everybody's severely malnourished. Don't get me wrong. I might have one a day or something. I might have more moderate malnutrition, but those do exist. I go around and when I teach physical assessment for dietitians, I was at a hospital and a patient who had just come in for a G-tube because her dysphagia had worsened. Had every physical sign. She was perfect. She was cute as a little lady too. But she had the micronutrient deficiency signs. She had the muscle wasting signs. But her only diagnosis was dysphagia and then for G-tube. So for reimbursement-wise, by adding severe acute malnutrition, that also helps your bottom line of your hospital. So I think my answers to this would be see what you can do automatically. Let the electronic record work for you if you can. Get as many disciplines involved. And then determine, do you think it's a worthwhile endeavor? And just to kind of show you, this is based off a patient who comes in, has colon cancer, came in, had a total abdominal colectomy with endoleostomy. His only other comorbidity was hypertension. So this is what CMS looks at. They look at mortality risk, severity of illness. That puts him at a 1-1. So his estimated reimbursement for his stay, however long that is a little over $12,000. If he gets an ileus, on top of that, they can code the ileus. His estimated reimbursement at that time is $18,000. If you add severe protein calorie malnutrition, maybe the guy didn't know he had colon cancer, right? It's at home, they wait, and they've lost a lot of weight. That's what brings them in. Find out they have colon cancer. That reimbursement is $35,000, adding that severe protein calorie malnutrition. So it can make a difference in probably more so outside the ICU, to be perfectly honest, because we have so many diagnoses. We're probably going to recoup our max, but it's something to keep in mind, I think, to make sure we get into the habit of diagnosing that and risk. And so as we're assessing these patients and determining, I think we've got our physical assessment, we look at our comorbidities, but we're kind of starting to look at new technology as well. I always want to put this up there. Remember, you do not look at these for nutritional status, your protein markers. They are a good indicator. I don't mean that you shouldn't get albumin and look at it. It's a very good prognostic indicator of how well someone's going to do in their ICU stay. But it's more a reflection of their inflammatory response at that point. But that also, we're starting to think, well, maybe we should be looking at the CT scans, mid-thighs, ultrasound. These are just in their infancy. We don't have good data yet. But to maybe able to track this muscle wasting. And then once we've proven that we can track it, then we can say, can I do anything to change the direction of that wasting? Is anybody doing any of these kind of things? Yeah. But you all want to start, right? Yeah. Dietitians can do this. You can do the ultrasound in any ICU that has an ultrasound. Some of the things I think that we're figuring out is how do we determine caloric requirements? A lot of people always want me to say, Beth, what do you do? What do you use? And really, there's not a great answer for the ICU. So how many of you use indirect calorimetry, which is our gold standard? So I see one person, two people. How many have a cart that works? Okay, that's about what percentage of this room is that, right? So we don't even have a cart. So then we are down to predictive equations. There are some predictive equations that have kind of touted more the Penn State, Ireton Jones for critical care. But if you look at the validity in the ICU, they're only going to hit about 70% reliability validity against indirect calorimetry. So it's really our best guess a little bit, and we just have to know that's what we're looking at. So this is somewhere where we could grow and get a little better at it, and maybe as indirect calorimetry becomes more cost effective. So I think the biggest problem is finding who's going to pay for it. Department of Surgery, Nutrition, that's kind of our battle. The other thing, and what these two slides represent in these two studies that I mentioned down here over this past couple years, have shown us that we probably need our biggest emphasis of the macronutrients on protein. During times of stress, protein becomes the main macronutrient of choice that is going to be broken down no matter what we do. We talked about the obligatory protein loss in our patients. So again, we may need to be pushing that protein more than we have in the past, which can be a scary thing when you're saying, oh, this person needs 160 grams. But we also save people now that we didn't save when I started in this business over 25 years ago. So we also, what we do to our patients, the treatments, the continuous renal replacement therapy, the open abdomens, all those things lead to more protein loss, and where we didn't have those techniques in the past. So we have to keep all those things in mind when we're looking at how much protein our patients need. So the requirement's going to be really push that envelope a little bit. And that's just kind of the general. In general, and now I'm going to focus a little bit on a few special populations, and we're going to start with obese patients. How many of you take care of obese, critically ill patients? Every hand should go up. I imagine every single one of you does. And that can be challenging for a lot of different reasons. There's a lot of data out there now that shows you how many children and adults are with obesity that are hitting our ICU. And there's a lot out there that shows that obese patients have higher morbidity and mortality, a little bit older data. And then there's the thought that the obese patient has always this little bit of inflammatory response at baseline. So it's like a two-hit immunological model. And kind of what that's about is that, and this is more theoretical, I think, but probably true, that our adipocytes, we set those down at age 5. If we gain weight, they just get bigger, and those larger adipocytes can lead to an increased production of macrophages, which kind of has this relationship here, leads to these increased mediators that then kind of downstream lead to this pro-inflammatory kind of low boil that we'll see in some of our obese patients. Now, some will argue that may be somewhat protective because they're used to a little bit of inflammation, so it maybe doesn't hit them as hard. And some will argue that it may be a detriment. And part of that argument comes from this, which is often thought of as the obesity paradox. And what that means is this is a BMI. You can't see right here, it's BMI less than 18.5. Here's over 40, mortality, morbidity. Low BMIs, mortality, morbidity high. In here, in this BMI to 25 to 35, it seems protective almost. And once you get up to 35, over 35, 40, your mortality starts to go up again. Now, a lot of this hasn't been explained yet. There's a lot of theories going out there. Some of my own opinions, and is BMI works well, and some of us that were at lunch today heard this when we were having lunch with Dr. Buckman, is a great big thing to look at in studies for the population, but it doesn't tell you much about components. So how many times do we see someone with a BMI 25 or 30 that's built like a brick house? Because they're very musculature, right? So part of this is, I think, that you need to, within these BMIs, take a closer look at what that patient is. Is that patient a BMI of very little muscle, maybe a sarcopenic obese patient, or is that a football player that has a lot of muscle mass on? And that may, if we can tease that out a little bit, that may give us some of these answers about is it really protective, that number itself. I'm going to skip for just a second. And this is kind of what I mean. Is there a different? So again, we're back to risk, nutrition risk. So if I had a big burly football player, he may have less risk than someone with the exact same height, exact same BMI, but had a bunch of comorbidities. And that might be the trauma patient that I say, hey, let's take a look at that CT. And you don't even have to get the fancy programs. You can see the gray area of the thin muscle line at the abdominal rectus muscle and see that they have very thin muscle compared to like a normal CT. So it may be that we need to look at more than just that BMI to determine the risk of our patients, because I would say those two patients have a different nutrition risk. And then the other, of course, challenge, if I go back, right, from all our walks of life, whether you're the dietitian or the pharmacist, is they're challenging, right? Because you have to think about dosing of meds. If you're a nurse, you got to figure out how you're going to move that patient. We want early mobility. Well, you know, you don't want to hurt yourself. We now have, luckily, a lift in every one of our ICU rooms, where we used to have a lift in only certain rooms. So that's been a huge help. For tracheing that patient, sometimes the surgeons will tell you that's a bit of a nightmare when they go to try to do a trach. Ventilating with all that weight on that patient's chest as they're sitting there on their back. So there's a lot of challenges to obese ICU patients. And it really makes a challenge. I'm sorry to state, but this is one of my patients, and I had him take a picture for me. I'm like, this patient, I'm like, I want to see the wound when it's down. So this is an obese patient who has this huge wound, and I have to figure out how I'm going to feed her. What am I going to give her? Piece of cake, right? So is this a good time to put someone on a diet when they're in the ICU and they're that obese? So what would you guys do? That's your patient. How are you going to feed her? What kind of calories are you going to suggest for that patient? What kind of protein are you going to suggest for that patient? Anybody guess? Anyone want to say? Lady in purple, right there. What would you do? Yeah. Good. Well, students have to have an opinion. It's good. Yeah. Well, right. So this patient probably has a lot of protein losses, right? We know that obviously this is going to take surgery as well, but she's got some tissue that needs to be repaired. This is open. She's going to have some losses through there. She actually has a little fistula over here too. And so protein's going to be high. What about calories? Should I put this person on a diet? I get it. Why are you not? Okay, Go ahead. All right, so hypochlorite high protein. I think that's probably a good idea. We'll talk about that. So have you ever been rounding with a physician who says, Beth, and this has happened, of course, Beth, look at them. They've got a lot of cushion. There is no rush to feed that patient. Have you ever heard that? Is that true? No, right? So it's not true. And so it's a challenge, though, right? Because we need to say that permissive underfeeding is not the same thing as high protein hypocaloric feeding. So that's one of those big things. They're like, Beth, they don't need a lot. Look at them, put them on a diet. And they just pick whatever formula. And I'm like, yeah, no, that's not going to work. It's gotten a lot better now as far as if you try to make, with our bariatric formulas. Part of the problem, though, right, is the research. We only have retrospective small studies supporting this. So this is an area where we need better research, but these bariatric formulas are kind of new to the market. So there's some research I can tell you that's ongoing that we'll see if that makes a difference. But there's research to be done. And a lot of it is, and like I'm saying here, is there's not a lot of research out there in the obese ICU patient as far as the response to feeding based on what their body composition is and everything. And I think that right now we use the basic principles of critical care nutrition that the benefit gained from early enteral nutrition holds true whether they're obese or non-obese. So we do want to feed them early. We want to protect their GI tract. We want to protect the flora, their barrier, that type of thing. So I think getting started early in a patient, whether they're obese or skinny, is still a good idea. But when you're coming up to determine what am I going to get them, how am I going to dose their medications, comes what weight do I use? What weight do I use to calculate that? Do I have pharmacists in the audience? Pharmacist student? Come on. Okay. Pharmacy students, if you had to dose the drugs on that lady, what weight would you use? And okay, and that's what I would get for an answer. What's the research on adjusted body weight? Well, no, is there any research on adjusted body weight? Really, it's somebody, that just kind of got made up. There was really no research study, but this is where you have to look at kinetics, because a lot of it is learning. We haven't got it all figured out yet because we didn't have these super obese. Yeah, I don't ever use there's no research to support the use of adjusted body weight for calories. But I mean, it makes it difficult because my pharmacist and we always go around. I'm like, she goes, what's the adjusted body weight? I'm like, I don't know. I don't calculate that. But so, it's this quandary now with new drugs and stuff, what we're going to do. So dietitians, what weight do you use to figure out their calories? Wait, you just heard I don't use adjusted body weight, but it's okay if you do. That's fine. Dietitians do. Actual body weight, okay. How many of you use actual body weight? Okay, me too. So if I'm going to do actual, so my A stands for actual, not adjusted. When I look at caloric provision, so again, I'm doing hypocaloric, high protein. It may be in the range here, 11 to 14. Some patients are more like 9. I tend to not go over around 2,000 calories. But if you want to use ideal body weight, this kind of gives you a justification of where you would use if you're using ideal body weight. But then you think about your protein, depending on what class of obesity, and you need to push your protein up. But that I base off of ideal body weight. Because even though our patients, and again, some of that is, you have to actually go in and look at the patient and use some clinical judgment. Because some of our patients are more muscle bound, so they might hit higher. But even though they're heavier, they tend to have more muscle mass underneath than their lean counterparts that we're trying again to save. All right, so summary, kind of in feeding and taking care of the obese, I would just say take a moment and think about their other comorbidities. Are they the high risk or low risk obese? Because I think it makes a difference. I agree, hypochlorite, high protein strategy, because our goal for these patients is to help mobilize their fat, preserve their lean body mass. There's a lot in metabolics right now looking at, there's one study out there that looked at ability to metabolize fat between obese and their lean counterparts. And the obese patients only got their energy from 37%. They only metabolized about 37% of their own fat for calories, whereas lean counterparts was around 63%, probably because they're more insulin resistant. So they have this little futile cycling of lipid mechanics where they have lipolysis and lipogenesis kind of going on at the same time. But those, again, is another area where we really need to look at. Now I'm going to just switch and talk about immunonutrition for a few more minutes. Been a rough couple of years for immunonutrition, if you're following the literature right. There have been some very large negative trials, starting with the ARDSNet Omega trial and Stapleton trial. Those both showed no benefit in using a fish omega-3 fatty acids in acute lung injury or ARDS. And then just recently, we've had some of these large negative glutamine. How many of you have heard of the Redox Trial? That one's got a lot of press. The Meta Plus just came out a little bit ago. And most of these are on mixed ICUs. And all of these were negative trials on intraoral or parenteral glutamine. So bad press on immunonutrition. And you have to, there's been a lot of debate kind of back and forth, but you can't argue with the fact these were large number trials. And so we have a few prospective randomized controlled trials out there that have positive, but these big trials are kind of like the big fish in the pond now. So they're showing that negative outcome with giving glutamine, and in one case in the MetaPlus, there was an increase in 6-month mortality. I'm not sure what to make of giving a week of a product with glutamine in it in the ICU, how it affected 6-month mortality, but the data is the data. So, and if you look at the design, like the Redox Trial, there's a lot of pushback for the believers, but I think they did a pretty good job on how they set it up. It was a 2-by-2 trial. Whereas they had glutamine and antioxidants, some got both, some got one or the other, just to see if it made any difference. And these were sick patients, right? These are like the patients we take care of. In the Redox Trial, they got both IV and intraoral glutamine. This one probably had this, and the MetaPlus is the one that your docs are going to talk about the most. This was a smaller trial, and it gave quite a bit of glutamine, 30 grams total, plus the fish oil. Again, really sick patients like we're used to. No difference on anything except for 6-month mortality. Now there's some small randomized controlled trials that were actually really well done in burn or trauma patients that showed all benefit to glutamine. And so if you tease out some of these other larger trials, those that did some subset analysis, you can pick out some of this, but there wasn't really burn in those patients. So I think also as you practice, I know some of you are neuro, some of you are MICU, some of you are SICU, is you need to think about your patient population and also look, can I extrapolate that information from that big trial? Because a lot of those are medical ICU, pulmonary ICU type patients to my surgical ICU or my burn patients. So after seeing that, how many of you use glutamine? Okay, who do you give it to? Wounds. And keep in mind are they ICU patients? And it's hard to say whether she's right or wrong, because none of these trials, and I didn't mean to put you on the spot, but that's my point, they didn't say, okay, well, what if they have a wound? Or what if this or that? So you have to keep in mind again that there's more to be known, but as a rule, so what it probably tells us is, okay, who am I going to give it to? Well, if you look at the Canadians, they said just maybe burn and trauma patients, those with the big injuries, wounds, but it shouldn't be used routinely, okay? And they warn against it here. Our recommendations will come out and will be probably a little stronger than that. But probably that means that now it's not like, you know, you have to throw everything at every patient. Again, it's determining risk, I think. So not everybody needs glutamine, but there may still be some subpopulations, and you need to look at that data in those specific populations. And I want to bring up just a little bit about meta-analysis as we look at some of these immune decisions that we make. Is for the guidelines now are all done using what's called the GRADE criteria, which is a brand new criteria. But basically, it puts everything together. It's a way to look at things in meta-analysis. So meta-analysis are you take a bunch of small randomized controlled trials, you put them together so you got a big population, and you see if you can get a signal. And then as time goes on, as new trials come out, you add it to the group, and you see if the signal changes. So that's kind of how guidelines are shifting to that type of looking at the research as a whole instead of individually and for big questions. And so if this was a meta-analysis of this 26 over almost 2,500 patients that came out in 2012, using this new system to stratify the quality of the studies, and then you see the results where they showed some benefit. Now, this was all in surgery patients. So again, that's why when you're looking at the data, think about your patient population. So in this open GI surgery patients, they found that it was beneficial to give these patients immunonutrition. This is another one in surgical patients. Some of the same studies will get included. So when you have a new meta-analysis out, it has some of the same studies the other meta-analysis had, all right? So if there's one study that's really driving the meta-analysis, that could make the difference. Again, kind of showed the same thing pre and post-op, that it made some difference. But a lot of them, you'll see this, no decrease in mortality. So also look at the outcomes and think, does that outcome make a difference for my patient? Well, living or dying kind of makes a difference, right? So if it changed mortality, that would be good. But is it also getting out of the hospital sooner? Would that be important to our patient? Not having an infection and the costs that go along with that, would that be important to our patient and our hospital administration? So I think also as we do nutrition research, and I hope you all become researchers, because my favorite thing is to do research right at the bedside, is maybe we need to think about what our outcomes are that we're looking at. Mortality may not be necessarily what we're going to affect, but with looking, because we saved so many people we didn't save 25 years ago, that we may be affecting their quality of life when they get out, that they can move, right? That they still have some muscle mass, that type of thing. So this kind of shows you what you'll see in the guidelines when they come out. This is not the guidelines. This is from Emily Oslin, who did a pre-op immunonutrition meta-analysis, that you'll have these forest plots of all the different trials and which way does it favor. So as far as length of stay, immunonutrition was favoring the pharmaconutrition, and infection also favored pharmaconutrition, but again in surgery patients. So this is the summary of immunonutrition. General ICU, probably don't give everybody glutamine. Don't give everybody immunonutrition. There is actually now in ARDS, acute lung injury, in ARDS, there's not a good recommendation to stand on to give any omega-3 fatty acids. You know, we all did that because, you know, when these early trials came out, it showed all these benefits. But these were well-done trials, big, thousands of patients that showed no benefit. So probably what's most important is just feed them adequate protein and calories, and they don't need all the fancy stuff. Save the fancy, expensive formulas for those where you've had proven benefit more in your surgical trauma, burn, kind of ICUs, and then some in head injury. There's some good data in head injury. And this year in the guidelines, when they come out, we've added new sections. So we've added surgery, trauma, head injury, obesity, chronic critically ill, and pancreatitis. So that's why it's 123 pages long if you want to read it for a little light reading. But you can zero in. The hope was that people would use the sections that they need. Okay, so think about what the products are right now in your formulary. Do they differ? So don't just go grab something off the shelf. Really put some thought into what you're putting into your patients. And I think we're going to stop there. The next part is all about barriers, but you guys have that, and I'm going to let you do that one on your own because we all have different barriers. So we have some time for questions. Got a little late start. So do I have any questions? You can ask me anything that I talked about or specific ICU question. Yes, sir. Okay. So what his question was, what about feeding patients on pressors? So, and that's a great question. There was actually an article out in JPEN not too long ago, maybe last year, where it was done by 2 pharmacists where they did kind of a retrospective review and looked at pressors and what when they had issues. So the main issue with feeding on pressors is you're worried about non-occlusive bowel necrosis or getting an ischemic bowel. And what you have to think about when I address feeding someone on pressors, I'm really looking for signs of end organ perfusion because that's what the GI tract is, an end organ perfusion. So if I'm in the neuro unit and we're using our pressors to keep someone's MAP at 80 to be protective, but they're making urine, their fingers and toes are warm, that type of thing, they're showing me signs that they have end organ perfusion, so think about your organs, then I would be fine feeding that patient. And generally in my surgical trauma unit, if we want to get hemodynamic stability, so if they're on what I'd call multiple pressors. So if I have someone on one pressor and they're coming down, then I will start slow feeds and titrate up and do a close examination, watch their abdominal exam, that type of thing. But if they're on multiple pressors, those are the patients that it was a retrospective review. Unfortunately, that's the prospective trial we'll probably never get to do, right? Because the risk is non-occlusive bowel necrosis happens in less than 3%, maybe even 1% of the patients, but it carries almost a 90% mortality. So that's the problem. But so really to answer your question, because that's what I always get asked, Beth, what number can I start? I don't look at it that way. I look at it as an individual, that you really have to assess that patient individually. Normally we know we need MAPs above 60 to get some blood flow to the splenic circulation. So I want to make sure their MAP, their mean arterial pressure, is hitting at least 60. And that if they're weaning off multiple pressors, some pressors act differently. Norepinephrine, and our pharmacist can tell you this, if they're fully resuscitated and they're on a little bit of levo, they're still going to get good microcirculation to the microvilli, oxygen circulation to the microvilli, which is what you're worried about because that's where the ischemia starts. Whereas vasopressin, which is a vasoconstrictive, they get poor circulation. So, a lot of vaso, maybe not. But then I have my physician. Are you a physician here, sir? So I'm going to put a question back to you because this is one of the things that I go around with my physician. One physician feels that 0.04 of vasopressin, a drip at 0.04, is just replacing what they're lacking. They're deficient. Like if we give arginine to a trauma patient because they have upregulation of arginase and they're deficient. Whereas others see it as not a replacement of a deficiency, but actually a treatment. So I think some of it is how you interpret that as well. But if I had to give you an answer, I would say a multiple pressors, I would hold off on going beyond a trophic feed. But let me be clear, I would still trophically feed them. Does that answer your question? Yeah, and if I have to give a number 10, that article I told you about, if they did it all catecholamine equivalence with norepinephrine, it was 13.5, which that cut off when they looked retrospectively of when some complications occurred. So what usually the rule, and my critical care fellows are funny because they're like, God, Beth, I can't get around this rule. I'm glad you're back at work, but if the patient hits 10 mics, depending on how you do, if you do weight-based or not, but if it comes out to about 10 mics per kilo per minute of levo, they'll hold the tube feeds until a discussion can be had with the medical team. And then I feel bad decisions are best made in groups, right? So you can look at the whole picture. And that the buck stops with him, not me, so it's his name on the bottom line. But then we talk about it and we look at all those other indications. And so that's kind of our cutoff too for having the discussion. Mm-hmm. Any other questions? Yes, ma'am. That I can't really talk about, I know. Uh-huh. Right. Mm-hmm. And I think you could probably be very right. I always say the answer is going to be peptides. I know it someday, whatever the answer is. But she brings up a great point. So also when you look at the studies, because we're kind of zeroed in on the formulas that we have, and they try to make it isonitrogenous with the same type. But some of them are whey, some of them are casein. So there may be a difference, and it hasn't been teased out to my knowledge. And I just looked at 400 and some odd studies for this guideline, and we didn't really have one that showed, where different types of protein were compared. So I can't answer the question. Mm-hmm. 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 Right. It's sort of like when you give, like when we used to give the glutamine to everybody, right? It's a very high nitrogenous amino acid. So you may be given, 15 grams of glutamine translated to 18 or 19 grams of protein if you're thinking about general protein. So it might be interesting to say if we could translate it to, then you could take those old studies. Actually, you could do that. You could go back and look at the protein used and give them quality scores and see if studies that use different proteins had different outcomes. There you go. Got a research project. Bada boom, bada bang. Right. Mm-hmm. And so the one response I would have is, at least I know when I'm parenterally feeding them, they get 100%. Because the truth be told, we can say we want to give at our goal, we're going to hit 140 grams of protein, but how often are we at 100% for an entire week, especially in the first week at the ICU? We do abysmal. I mean, so I'll report on rounds and say, hey, this liver transplant for the past 6 days has gotten 40% of goal. So I can tell you that, we're not getting there. So I think a lot of it is just getting in kind of what we prescribe. So I mean, that's kind of part of the barriers in looking at it. So really, it's true. Maybe it'll make a difference in the type of protein, but you still got to get it in there, and they got to absorb it. So that's very good question. Not really answered yet. See, even now we're still in our infancy, because there didn't used to be all these different types of protein that we had available. Everything was caseinates, and now all of a sudden they come out with all the new proteins, and we don't know. They want to sell it to us. We just don't know if it makes a difference, but we should find out. Any other questions? Yes, ma'am. Go ahead. Yeah. Mm-hmm. Yeah. So she's asking about volume-based and how where does autophagy play in and the cell's own destruction and that type of thing. The answer is it's just theoretical right now. I'm really excited for Aspen coming up because there's a couple of talks where we might get some new data. But so I don't have an opinion right now. I don't have enough information to give you an opinion. Dr. McClave did a talk on it, and we've even had some, I'm like, well, what do you think? And until we know one way or the other. But with volume-based feeding, and I think you do whatever works in your environment. We did a knockoff of the PEP-UP protocol we called the Feed Me. But still, with that, we brought our total up to meeting 80% of goal in my SICU patients who are MPO a lot of times for different things. So I'm not worried about it so much at this point until I see that we're making 150, or, you know, those kind of things. So right now, I would say I still am a proponent for volume-based because I know without it, I'm hitting 40, 60% tops. And I'm not getting to 100%. I'm not ever going to hit, but I'm trying at least to keep over that 60 or maybe hit the 80%. But I think it's kind of an interesting concept, and that's a whole talk in itself. And so I saw there's a few talks on it coming up. Other questions? Do we have questions online?
Yep, we do. If you want to step around.
Okay.
All right. So
Glutamine and arginine for so the answer is no, don't use it. So arginine and sepsis. So there's the thought that with the increased arginine, you have increased nitric oxide production, and that can worsen the septic response somewhat. So there's always been a caution with using arginine in full-blown sepsis. Now you're like, how do I know who's going to be septic, right? I think you go into it, if I have a big trauma, and it's the big trauma, it's not the person with the broken arm, it's the multi-trauma patient that I'm going to give my arginine product to. If they turn septic, I may switch them over to just a high-protein standard product. So my answer was you should not, at this point, based on the data we have, use that in multi-organ failure or sepsis, either one. OG versus NG. So how many of you keep track of your wounds? Because remember, we all have to turn those in, and we get knocked down if they have a hospital-acquired wound. Well, a Nares wound is part of that. So we try to use more OGs instead of NGs just for that reason, so we have less wounds. If we do use an NG tube, we've trialed all these different ways to secure it, so there's some more free movement. But sometimes when they come out to us from the OR where they've taped the NG tube up to the, for however many hours they've already got the breakdown started. I mean, that's the only difference between OG and NG is whether you're going to get the wound or for a prolonged period of time sinusitis. But I will jump up and down. If you're not needing a Salem sump for decompression, take it out. You can put a softer, more gentler NG, feeding NG in. That won't cause those issues. What do you do with enteral nutrition in Crohn's ARDS patient? Post-pyloric, cold feeds, trophic only? I post-pyloric feed them. So if we're going to prone somebody when they're flipped up, we put the post-pyloric tube in. It's easier because we can put them in at bedside. They don't have to travel for that. Those are one of the few patients. I think 90% of patients you can feed in their stomach in the ICU, but there are those cases where it makes more sense. And that's one of those where we would put a post-pyloric, and we would go to goal. Anything else?
Yeah. This may be a similar question to the text question. Would you recommend high protein, hypochlorite feeding and withholding lipids in some of these patients like ARDS versus giving them lipids?
So I'm meaning that is talking about parenteral lipids. So of all the guidelines that are coming out and all the recommendations, we were very transparent. We did anonymous voting. We had 85% or greater agreement, and every single recommendation save one whether or not to give lipids within the first week in the ICU, and it was a 67% consensus. So that's a tough question because it's split pretty much almost down the middle. You know, one person could have tweaked it one way, because the data on not giving lipids is from the Beth Taylor study, which is a very old study, well done, but it had its own issues. We acknowledge that. So kind of what we're going forward with is that if you are concerned that they have essential fatty acid deficiency, which some of our patients may at the get-go, and they're not getting propofol or something like that, which is also a source, and you feel the need to give lipids twice a week during that first week to meet that need, that's probably appropriate. And so there's a little bit of, this is going to, it'll be a change, but I didn't say it. I'll just going to deny it. Nobody listen. So that pendulum has swung a little bit the other way. Now what's sad is and part of it is right now we only have the soybean-based lipids available in the U.S. Fresenius keeps telling us, Baxter's keeps telling us anytime the one's been approved, but we haven't seen it yet. So the data for the omega-3 and structured lipids parentally it looks really good, but it's hard to make a recommendation based on something you don't have, right? So yeah, good question.
That's all the questions I have. Any other questions from the audience?
They're like, no, just tell us who won. Oh, yes.
They were receiving only about 50% of what we thought we were going to get if we really looked at it. And looking at the literature, actually, there's actually statistics that's known. So there's actually some sort of an argument for combination partial TPN and partial AOC, because it's not actually using nutrition.
So that is a question that will be answered in the guidelines as well. When do you add supplemental parental nutrition? And some of it is going to come back to where I talked about risk, nutrition risk. So those low risk, well-nourished patients, you would, let's just say, could probably wait a little longer than the high-risk patient that you're consistently not getting there, that you may need to address the fact that, because you would need to get that exogenous protein in. So that pendulum has swung a little bit as well, because we know we're not doing so great. You know, we're trying to break down barriers, and we want to do enteral nutrition, but sometimes it does take a combination. And there's been some large trials that have come out, Dr. Doig's trial, looking at early parental nutrition. It didn't show a benefit over early enteral, but it didn't show an increased risk of infection, which is what we've always touted. Oh, don't do PN, it's poison, right? They're going to get an infection. But we're smarter. I remember when it was called, does anybody in this room remember Hyperal, or is it just me? Okay, anybody else know? Where we gave lots and lots of calories and we didn't worry about glycemic control, but those are the studies of the 80s that we based a lot of the recommendations off of. So if you look at this new data where we're smarter, and they have people like nutrition and pharmacists that are keeping track of these things and doing glycemic control at the same time, and watching for signs of bacteremia and that type of thing, that you can probably do it safely, and perhaps gaining fat is more important. So there will be recommendations that address that. Gosh, don't you just all want to go get your copy now? 1 month. It only took 5 years.
All right. Well, I think that's all the questions that we have. I'm going to take your microphone for just a moment so I can address the remote sites. And I want to make sure that we give Beth Taylor one more round of applause. She came out here all the way from St. Louis to speak with us. I want to thank all our remote sites for participating, and those who are viewing remotely on their own as well. We want to thank you and hope that you'll join us for our next meeting in February. And we hope that we'll see you at SCCM at our annual business meeting as well. So thank you. At this time, I'd like to adjourn the remote sites. If the Atlanta site could stay behind for just 1 minute, we're going to finish up here.